Welcome, everybody. This is Trish Riley from NASHB, and I'm very pleased to welcome you to today's webinar, How NASHB's Model Legislation Increases Health System Financial Transparency and Provides a First Step to Address High Hospital Costs. We're really pleased to be here, and we thank Arnold Ventures for sponsoring this webinar. It's an important discussion, and we look forward to your conversation. Throughout the webinar, you can add your questions into the chat box, and we'll make sure they're answered as we go along, and certainly at the end of the presentations. And we'll respond just throughout the session. So please make sure you add your questions to the chat box when they come up. At the close of the webinar, I'd really appreciate it if you could follow the link to a brief survey. We really need to know from you how these webinars work. Get a little bit of feedback. I guarantee you it takes no longer than a minute or two. And we hope you'll stick with us and do that survey at the conclusion. So before I introduce our terrific panelists, let me just frame the discussion. Obviously, NASHB has spent a good deal of time on pharmaceutical costs, but we all know those still make up just a small portion of healthcare costs. It's hospitals that are the drivers of healthcare costs. Hospitals and physicians, more than half of all healthcare costs. As we see increasing consolidation, both horizontal and vertically in hospitals and health systems, we see costs increase rather significantly, a big concern for states. And in tough budget times, states that are responsible for public dollars, state employee health plans, who have oversight of insurance rates, and obviously the impact of high hospital costs drive those premiums. We have concerns about community benefit and the tax exempt status of nonprofit hospitals and where those dollars are spent. All of those issues bundle up into some concerns about how hospitals are financed. Of course, hospitals are not a monolith, despite consolidation, and we need to keep in mind when we're talking today that there are different kinds of hospitals: tertiary and teaching hospitals, community hospitals, safety net, critical access hospitals. All have different needs, different financial realities, and we'll speak to that as we move through the discussion. The need for high quality hospitals is unequivocal, as seen by all the work in COVID, but that doesn't mean we can sit back and not directly address the issue of healthcare and hospital costs. It's a tough needle to thread. We know that hospitals are very significant employers in your state. They have powerful, powerful lobbies, and we need to balance that against what is a reasonable cost and an appropriate cost for hospital services. So the first step in answering that question is transparency, to standardize data across hospital systems in a state, to compare key criteria across states, and to monitor market behavior over time. Notably, the new COVID expenditures, the CARES Act expenditures into hospitals, require some accountability. Where did it all go? What was its impact? So we wanted to really have this opportunity to talk with you about the new tool and to put it in context with some really great experts. Some states obviously have begun this work already. Many states have transparency laws in place. We here want to talk about a new kind of transparency law that gives you better access, broader access, answers more questions. So we'll answer a couple of questions. Again, remind you, get your questions in the chat box as they come to you. And let me introduce our speakers as a group. Our first speaker is Nancy Kane. Dr. Kane's an adjunct professor in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health. She's been an instrumental partner in NASHB's work and helped craft NASHB's model law and tool. Jeremy Vanderhey is the director of the Health Policy and Analytics Division in the Oregon Health Authority and the point person for their transparency work there, as is Vicki Veltri in Connecticut, the executive director of Connecticut's Office of Health Strategy. So with that quick introduction of these fabulous people, let's move right in and begin with our first question. How does hospital and health system financial transparency help policymakers address rising health costs? And I think, Jeremy, I think you can kick us off.
Great, thanks, Trish. I think many folks know this, but I think it's always good to start with a little bit of context and just a reminder of why this conversation is so critically important. We know healthcare costs, including hospital costs, have been growing, frankly, exponentially, much faster than the rest of the economy. Healthcare makes up about 18% of gross domestic product nationally, and that's expected to climb to about 20% in the next 8 years. Nationally, healthcare costs have been growing in the ballpark of 4 to 4.5%. But CMS projects, granted these are pre-COVID projections, but CMS projects cost growth to be in the ballpark of about 5.5% per year over the next 8 years, and that's more than a percentage point over gross domestic product, in which case will healthcare become about 20% of the economy. We also know that according to a recent HCCI report, that from 2014 to 18, prices accounted for about 75% of increase in spending, and CMS projects that price increase is going to be the largest component of cost growth over the next several years. So I want to talk first about why I think it's so important to have state level data. I just rattled off a bunch of national numbers, but frankly, the data we get from CMS is often several years outdated, and we've just found it very, very critical that we be able to have more timely local state data to be able to measure what's going on. The chart here is from our all payer claims database, not from hospital financials, but I think just emphasizes why it's important to have state level data. When we started to look at how we were doing as a state on spending versus the national trend, we found that over the last several years, we've been growing at 6.5% per person per year, compared to that 4.5%, which is with that middle line of the national average. So that was critical to tell us that we have a real problem as a state and that we need to really get our arms around per capita spend. Hospitals are, a really major component of this, and I'll talk a little bit later about the work we've been doing, but we've been measuring hospital financials for several decades now. Hospitals are a very large component of the healthcare system. They aren't the only component, but they make up a large and growing portion. About 33% of total healthcare spending goes to hospitals, but that's really for inpatient and outpatient hospital services. I think as we think about hospitals that have acquired or affiliated different parts of the delivery system in their community, I would venture to say that the amount that's of spending into healthcare that's controlled by a hospital or health system is probably over 50%. And so it's just really important to understand what's going on there. What's the financial system look like? As Trish said, I think it's not one size fits all. There's lots of different hospitals with lots of different challenges, and we see a lot of different spend and margin changes depending on the type of hospital and their various financial situations in a given year. We, as an example, saw last year in 2019 that our hospital margins were about 7.3% statewide, but that wasn't the same experience of every hospital. Some hospitals were in the red despite, on average, about a 7.5% margin. We also know, coming back to prices, that the hospital prices are a major driver. They're not the only driver, but they are a major driver of cost increases. There was a recent RAND study that showed in Oregon that we're paying about 241% of Medicare for hospital services. And as I mentioned, the projections are only the prices are going to continue to go up. So finally, let me just end by this, and I'll turn it over to Vicki. Knowing that the other thing that's really on our mind is what's happening in light of COVID, and I think in particular concerns around further market consolidation and what that's going to mean for consumers and what that's going to mean for costs. COVID sent shock waves through the health system. Saw as much as an 80% reduction in revenue in April, and again, that wasn't the same across the board. We knew from our hospital financial data that we had hospitals that were sitting on a year or more of cash. And we had providers that had less than a couple of months, and in particular, our primary care providers have said that the majority of them have less than 6 months, and actually a very large chunk have less than 3 months of reserves. So I think that really sets up a dynamic of the potential for much more rapid consolidation of the delivery system, and the evidence is pretty clear that when there's been consolidation and there isn't a market balance, that the prices go up, and ultimately that impacts consumers and impacts premiums. So I think it's really critical now. I think it's a really timely conversation, and applaud NASHB for hosting this and taking this work forward, because I think it's a critical time now for states to really think about how they monitor the financial health of their healthcare system.
Thanks, Jeremy. Vicky.
Thanks, Trish and Jeremy. Both of you have made similar points that I would make in this presentation. First, I want to say thank you for putting this together. I think this is a really critical issue for states to be looking at. As Jeremy said, Trish said, we know hospitals are really important economic drivers in the communities. We have various size hospitals across our sector, as Trish, excuse me, alluded to earlier, very large systems all the way down to the smallest community hospitals. However, they all have one thing in common, and that is they serve a public mission. So for us to know their financial position is very important to serve the public good. Most of the hospitals in Connecticut, as in many states, are nonprofits. So they have a particular mission to serve their communities. And it's important for states to have an eye on how those hospitals are performing in light of those missions. Again, hospital costs have been the largest part of the spending pie. They contribute the most in terms of costs to public and private insurance plans. We monitor that every year. We can tell what the payer mix is and how hospitals are contributing to the overall premium dollar. So it's really important that we see how that changes over time, how hospitals are contributing, maybe in a good way or not, but we still need to know how they're contributing. Again, knowing how hospitals are performing financially is really critical to future planning for the market in Connecticut and elsewhere. If we know that hospitals are financially healthy in certain areas and not in other areas, we know how to target remedies. We know how to improve certain hospitals who are not doing as well compared to other hospitals. We also may know that some hospitals are performing extra well, as we say, or margins in the double digits. In Connecticut, we have quite the variety of margins. We have margins in the double digits for some hospitals and some hospital systems. And we have other hospitals who are in the red. So it's really critical to know how actually they're performing vis-a-vis their margin, but also for future planning. Do we want hospitals who are performing very well to continue expanding in certain areas of the state? Do we want them to do it at certain price points that they have, or do we want them to lower their price points? Hospitals who are performing poorly, should we continue to subsidize those hospitals? Should we help them? Or should we let them keep expanding services if maybe they're not performing well overall? Maybe there are efficiencies to be gained somewhere in the market. It's really critical also to have this transparency to see what's happening in the market. So as was alluded to before, we see horizontal mergers and acquisitions. We see hospitals acquiring other hospitals. We see hospitals acquiring practices affiliated with other hospitals when they acquire those hospitals. We can't tell what their performance is over time, whether the systems are doing better or worse, unless we see their financial performance. So we need that transparency. We also need to see what's going on, as Jeremy alluded to. In the era of COVID, we have very big worries about primary care, in particular, being absorbed into larger systems and what that might do for price points, access to care, and how that will affect the financials of the hospitals that are doing the acquiring and or the hospitals that are losing practices if those practices have lost practices in an acquisition. There's also the chance to look at increased capital costs. I think one of the things we've seen in Connecticut, we don't regulate capital expenditures in our state. Kind of wish we did. I think it would give us a better idea of what's happening that's outside some of these financial reports in terms of the ability of hospitals to take on, let's say, building additional buildings in other locations where they may or may not be needed. So we need to see their numbers for that. And also we can see what's happening over time with expenses and revenues. In Connecticut, what we've seen over the last couple of years is substantial increases in expenditures on the order of hundreds of millions a year. And so obviously, if you're leading with expenses, you have to have revenues to catch those expenses. or your margins will be negative. But examining the financials and details and having this transparency allows us to tell whether those expenditures are really for the kinds of things that we think expenses should be being incurred for. Finally, a couple areas. What's happening in the inpatient space versus the outpatient space? I think things have changed over time. We all know that. We're seeing lots and lots of expansion into outpatient care, and you're seeing a reduction in some of the inpatient costs. So what's happening over time? You can't see that without financials that show that information. And finally, as Trish alluded to earlier, which I think is really critical, is tracking what's going on with COVID expenditures, how the hospitals are being hit and the systems being hit in the context of COVID with losses, but also how that's being balanced with relief funds coming in, which hospitals are better equipped to handle losses, which aren't. If we're going to target relief, who are we going to target it to? And if we're going to target relief, we want to know exactly how the hospitals are performing so we can target that relief appropriately. So those are some of the areas in which I think this tool really helps us look at rising healthcare costs and targeting relief.
Thanks, Vicki. Let's move to Nancy now.
Okay, thanks. Thanks, Trish, for inviting me in on this. I get to talk about the more boring parts of the tools of transparency. Many people,
the guts, the important stuff.
Yeah, thanks for letting me come after all the exciting policy issues come up. But I mean, just to clarify, my first job 40 years ago out of business school was to identify the reasonable financial requirements of hospitals. And it was kind of a joke because frankly, no one did anything in a standard way. There were no accounting policies. Balance sheets and income statements were kind of merged. Capital expenditures became expenses. It was a nightmare. And so it's a lot better now. We do have accounting standards for all these different disclosures, although they vary by the type of hospital, by investor-owned versus government versus nonprofit. But they are getting better, but it's become incredibly complex. So there's all these numbers and complexity, but there's some basics that we need to understand and try to standardize. For instance, the balance sheet. So people say, oh, they've got so much cash. Well, there's some of that cash is not available for general purposes. Others is. And it's very hard sometimes to tell which is which without standardizing that and actually asking often the health systems to be more clear about what these restrictions on their cash and investments actually are. Same thing on the income statement. Anybody who's looked at an income statement of a nonprofit, you'll see at least 3 bottom lines, sometimes 4. If you look at an investor-owned, you may see 5 bottom lines. If you look at a government hospital, you'll see 3 or 4 bottom lines, and they all are different. So there's a need to standardize even about the income statement, which seems so straightforward, revenues minus expenses, but it really is pretty complex. Many of you may or may not be familiar with the statement of cash flows, but it's a way to get rid of all the estimates that affect revenues and expenses and see where's the cash coming from, where's it going. You can't estimate away cash. Cash is cash. So standardizing these statements really helps you get not just a clearer picture, but also a picture in which you can compare across health systems and say, well, this is the operating margin of X system. I can compare it to the one of Y and say, wow, that's 5 times bigger or 3 times lower. And I don't have to worry about the fact that there's reporting issues that I didn't understand. And then, of course, once you standardize the statements themselves, you can then standardize the way you calculate ratios. There's many ways to calculate a current ratio, a day's cash on hand, a debt service coverage. There's many ways to do it. Just do it one way for comparability purposes. So these are the reasons. This is what we mean. This is what the template tries to do for you. It looks terrifying especially if you're not financially particularly literate, but it serves a huge purpose in helping create comparability and clarity in looking at financial statements. So I think our earlier panelists, Oregon and Connecticut, did a great job of explaining some of the things that they use standardized financials for. I've worked in this area for decades, and I've had clients from every agency of state government, Attorney General, Division of Insurance, state employees, health benefit people, even county tax assessors, certainly Medicaid and certificate of need people, and legislative committees as well. And also the federal government. There's many, many uses of this policy uses in many different domains for our understanding hospital and health system financial health. And so this is just a list of some of the types of issues that I've helped people deal with. And there's many, many more. Of course, COVID is the latest, but it will not, I can guarantee you it will not stop with COVID. And there's just, you know, Trish can attest to this. We created a standardized data set in Maine that's still ongoing. What is this now, 15 years later? And I'm happy to see that they're doing a great job of helping the state of Maine, the policymakers and the media and anybody else who wants to understand it, get a good handle on who's making money, who's not, who's got the cash, who doesn't, and what we need to do about it. So, so hopefully this will, you know, at least be enough of background for you to want to bother with these really boring tools.
Boring tools, they're totally vital. They're important. Well, why don't we move on? I would ask everybody, let's watch our time. And again, add your questions to the chat box. We'll leave plenty of time at the end, but the sooner you get them in, the better. So let's switch gears a little bit and just, how does this model and reporting template actually increase transparency? You made a compelling point about why we should. How does it do it? And I think, Nancy, you're going to kick us off.
There's a few things we can do with the template, and you know, states can decide exactly how they want to tailor it to the particular needs that they have. For instance, in Massachusetts, they not only ask for the hospital, which is an important entity, but keep in mind that a hospital is usually these days embedded in a much bigger organization. And in fact, a lot of the resources are not in the hospital. They're in the parent, where a lot of the cash or the long-term debt is, or they're in the physician practice, which has gets a big transfer, or in many cases, hospitals are transferring money out to other affiliates, including you know, educational institutions. So you can ask for what you want, but I will say the hospital alone is probably not enough anymore. And so the template can be used to do the health system, the hospital, and even the important physician groups. And I know Massachusetts is doing this at 3 levels, and I think Maine is doing it at least 2 levels. So you can decide the level, but it is important to get a picture of the whole, the health system, as well as the different affiliates. In terms of who should give you that data or how should it get standardized, unless you're ready to spend about 3 years learning to become financially literate, you want the providers to do the standardizing. So you give them the template, say, please, here's the definition of this line item, and start putting the right number in there so I don't have to figure out what you mean by your financials. And I can tell you, I standardize a lot, and I've had 40 years experience, and even I have trouble understanding what the particular element means. I have to use the footnotes a lot. And then standardization lets you say, here's what I want to know, not how you want to present it. Not just in the elements on the balance sheet or the income statement, but also in the footnotes. You can get a good handle on free care, on Medicaid supplements, on bad debt, and now the new implicit price consent. The words keep changing, but you can say, here's what I want to know, and here's the 16 different ways you might describe it. Put it in here in this place, and that's one of the real benefits of standardization, is that you can create a language that everybody says, okay, that's how we'll do it, even though that's not the way we like it. So that's some of the benefits of the standardizing.
Great, thank you. Vicki.
Great. In Connecticut, we've been getting hospital and health system reporting, both of them, for quite a long time. And we do exactly what Nancy said. We give them the tool, you fill it out. Here's what we mean by it. It increases transparency, I think, in the obvious ways. When you look at the tool, you get a lot of detail. As you can see on the slide, you're getting expenditures that are related to your patients, but you're also getting other spending. Lots of people don't think about hospitals beyond the patient, caregiving. And there are other revenue streams or other spending, including labs, including, you know, other facilities, gift shops, let's say, things that hospitals have. You can also see, and I think what's really important in the tool, and also the way we collect it, is changes in the payer mix. So are you getting more commercial patients one year or fewer commercial patients one year? Who are the payers and how much revenue you're getting from each? That's important to see over time. And you can also see from these data what you're getting from the practices. If the hospital or health system owns 10 different practices, you can see what kind of revenue they're getting from them. And over time, see how that's going on. And also, you can compare that to other hospitals or health systems, as Nancy was saying. And you can obviously, you can gather other revenue sources that you might not think of as traditional revenue sources, like certain hospital is in a value-based payment model and they're getting care coordination payments. Something not typically people think of as typical revenue, but important to gather. I think this kind of transparency tool gives you a truer picture of the financials as opposed to one-off asks of your hospital reporting, let's say for a particular CON transaction. It's more important to see it in a standardized format over time. Again, movement of funds for capital spending, I think that's really critical. If you're seeing movement out of certain areas that can be then used for capital spend, that's important to see what the plans are of the system and what hospital planning is going on, or health system planning more broadly. I like the idea of quarterly reports. Currently in Connecticut, we only do annuals. I think quarterly might give you a little better picture of how things are happening in a closer to real time kind of way. Unfortunately, we don't have that. It makes those Medicaid supplemental payments and other kinds of funding streams more transparent. Shows you cash on hand, what I think is absolutely critical, especially in the time of COVID. Having more accessibility to cash on hand, knowing what cash is on hand in a more current fashion is important. And finally, a really critical thing, hospitals are caregivers, they're also employers, right? They're caregivers, they're employers. We need to know what the fuller picture is in terms of how their health is with respect to their employment status, pension liabilities, how they can absorb those kind of costs. So many different ways that the tool increases transparency, and that's just a fraction of them.
Interesting. Thank you. Jeremy?
As I mentioned, we've been collecting hospital financial data for the better half of the last several decades. And it's evolved over time, and now we are to the spot of quarterly reports. And I would emphasize, I think that's really important, because trying to understand what's happening throughout the year is critical, comparing one year to the next. So we produce both quarterly reports as well as an annual report, which is in essence our Q4 report. We've been producing these as PDFs since 2014 on a quarterly basis. This year, one benefit of COVID and folks working from home is that we made a big switch in a lot of our data reporting to Tableau. It's been sort of on our list in the back burner, and suddenly with a combo of some folks working from home and some other things getting put on pause, we've made some big investments here, and I would say that's actually going to help in the long run. There's a lot of work up front, but then once we have that system built, we can just dump the data in there, and that'll actually speed things along. So now we've actually posted back to 2014 all of our hospital financial data and interactive dashboard. Folks can go in there and look at it any way they want. We look at, we've been producing these on very similar standard measures that are in the NASHB template. I think to Nancy's point, you can argue about the definitions and what's in and what's out. And I think, bad debt and charity care and uncompensated care are good examples of that. Lots of folks would like those measured a different way. And if you ask them what their bad debt is or what their charity care is, you're going to get a very different answer without a standardized definition. So to some degree, it doesn't really matter what the definition is as much as it matters that you understand it and you understand what's in and out and that you're doing it consistently. But we have gotten there over the years, and really standardize those definitions, which has been really important in legislative conversations and policy conversations and trying to compare folks. But we produce reports based off of bad debt, charity care, net operating gains and losses, net patient revenue, operating margin, total margin, operating expense, operating revenue. And we can understand what's going on with what's driving expenses, how much is going to payroll versus how much is going to other types of expenses, how much is a result of how much of the financial situation is a result of uncompensated care. So these have all been really important for at different points in time. We get questions from legislators or others saying, can you tell us what happened with personnel expenses? Can you tell us what's going on? I think in light of COVID, it's one of the questions that's come up, sort of what's going on with hospital expenses that relate to payroll when we've got elective procedures that are on hold. This has been used by the legislature over and over again in lots of different conversations. I'm a big believer of just get the data out there. Our role is to get it out there and let folks debate the issues. You can debate what the underlying reasons are for the numbers, but having a consistent set of numbers has been really invaluable and has really led to a lot of different policy conversations, from hospital price transparency bill that passed several years ago, to most recently, we enacted probably the most progressive community benefit bill in the country, and our hospital financials will be used to basically set sort of community benefits spending floors. And we'll talk about a little bit later as we're now moving into a statewide cost growth target, and this data will help us provide a lot of context around that. Just real quick on the COVID front, especially on the quarterly basis, it's been really important for us understanding what's been happening with net patient revenue and utilization. And I know it's a little hard to see here, but these charts show utilization on the top and corresponding net patient revenue on the bottom. And so this has helped us be able to monitor what's happening with the health systems. I wish we collected this across other providers as well. We had to sort of go out and survey primary care providers and try to find the data in other places. I think COVID has really highlighted that our systems aren't really built to understand the pulse of what's happening with finances in real time, or as much as real time as we would like. But nonetheless, I think having the quarterly reports has been really important. And I think measuring things like Vicki said, what's happening in trends of inpatient and outpatient care? How's the care setting change? How does that impacting finances and revenue? Are all just important things to be monitoring and to understand in the system. And finally, CARES Act dollars have definitely been something we've been monitoring. We know about 55% of the CARES Act dollars that have come in have gone to hospitals. And so just understanding where the dollars are coming so we can understand what parts of the system might be struggling and aren't getting relief from the feds.
Great. Vicki and Jeremy, both really helpful information. Before we go to the next question, the so what question, though, I want to take one step back. And Nancy, you pointed out hospitals have multiple bottom lines, which is sort of boggling just on the face of it, and how complicated their reports are. So as we move to a standard report and think about quarterly reporting, what will hospitals tell us about the burden in that reporting? And I'll ask all three of you, but ask Nancy to start just a lightning round about, is this creating a burden for hospitals to fill out a standard form? The value of it is certainly clear from these states.
Well, a couple things I have to say about quarterly reports. One is they issue quarterly reports for their creditors. So no, it's not an extra work, except to the point that they have to use our language rather than necessarily their language. But once you do it once, it's pretty straightforward. So no, it's not a burden because they're already reporting quarterly to creditors. Most hospitals do, most health systems do. In terms of its validity, though, remember that quarterly is unaudited. And I once did a study for Massachusetts on whether quarterly really was an accurate metric for what happened by the end of the year, and it actually was off a lot. So it's good to have, I think it's absolutely great for revenue expense trends during something like COVID, and worth having, but it's not verified and audited. And a lot of things are estimated and the estimates change by the year end. You have to kind of decide. So just be aware that they're good for indicators, but they change a lot by the time they get audited.
Vicki or Jeremy, anything to add about hospital burden? Have they pushed back, or are they filling out the standardization? Any issues?
Well, I would emphasize Nancy's point around. I think the quarterly and the annual audit are important because we do see those variations as well, and they give you a pulse check, and they're both important for different reasons. We've been doing it for so long. I don't want to speak for them, or maybe how they felt, a long time ago when we first started doing this. I certainly haven't heard anything recently, but I would say, there probably is an upfront needing to figure out how to start reporting this. But again, they use the data too. I mean, they use the data and their own reports and their own messaging to the media and the legislature around what's happening in the health system. So again, I think it behooves everybody to have the data, have it out there, and be able to use data to inform an understanding of what's happening in the healthcare system.
Yeah, it's hard for me to disagree with that, Trish. I think that's exactly what it is. I mean, the data works both ways. It's useful from all perspectives. So, and we haven't heard actually a lot of complaints in terms of collecting the data. I guess the issue becomes if it's this on top of 5 other different reports that you start adding on. That's when you hear the burden argument.
Yeah, that's fair. That's fair. Okay, so let's go to the next question, which is sort of the so what question. And Vicki, I was intrigued. You mentioned, I hadn't thought about the use of the tool to look at the hospital as employer.
Yeah.
and its ability to meet its payroll and its pension and its benefit requirements, all critical questions. So let me ask you to start with sort of what critical information will the model provide? How can it be leveraged? So what? So we have the information. What do we do with it?
Exactly. I mean, and I really think there's a lot you can do with it. Again, looking over time is a really critical thing. We have the certificate of need function in our office. You know, you may have approved a transaction or not approved a transaction, but if you've approved a transaction, you certainly want to see over time what a system or a hospital has done in terms of its ability to keep the prices down, if that was one of your conditions, to improve, obviously to improve quality, but also to just function well in the new system environment. And you need those financials to be able to do that. Otherwise, you're collecting one-offs again. And to do that in a state where there's multiple CON transactions going on, that's where I think a burden comes in. And so having financial reporting all year long is helpful in that case. Also, I mean, I think it's important just in CON. So for instance, I may not need to ask for additional financials. I may have to ask for additional financials, but if you're coming to me with a certain kind of transaction, it's close to your annual reporting, it's close to all your financial reporting during the year, I may not have to ask for extra reports. So I think it has the possibility of lowering burden for those other things that we regulate while using a standardized format in those regulatory functions. Again, I think it's absolutely critical to look at the market changes. We have a pretty concentrated market in Connecticut. So evaluating any changes to that or what we're seeing over time with, let's say, 1Z, 2Z provider practices that are getting scooped up, and what that's doing to price and costs in the system is absolutely critical. We don't have regulatory authority over those transactions otherwise. So one of the only ways we could see the impact is with financial statements over time. Again, looking at those financials may help us develop some models we could use to target, you know, the costs that we're seeing in those models. We, like Jeremy, have started a benchmark program in Connecticut, and we think seeing the financials is going to be absolutely critical as a companion piece to the kind of claims reporting that we're going to get to evaluate system costs over time. We also think the neglected piece in a lot of this is the quality side of the equation. So while we're looking at the financials and whether a hospital is healthy over time and how it's doing with respect to its peers, we need to pair that with its quality performance. Mm-hmm. How are you doing over time with respect to your financials? If you're collecting a 10% margin, but your quality is terrible, or vice versa, that's really critical for legislators. That's critical for the executive branch. Important to monitor over time. Again, seeing those changes in inpatient, outpatient, I think is important for policymakers. I still don't think our policymakers necessarily see in detail the changes that are happening in the marketplace, moving from inpatient to outpatient, and the financials really tell a story there that can easily, I think, be translated for our legislative colleagues. The other thing is to tie these data. I mean, these are financial data, but we have other data. We have an all-payer claims database. We have facility fee reporting. We have discharge data. We have to tie all these things together. We can bring, I think, a much fuller picture of the market's performance when we do that. If we just have financials, we get one thing, but pairing it with other data is critical. And again, you know, financials on their own may not necessarily tell you price variation over time, but with the reporting on the payer mix differences or intensity of services or those kinds of things, you can pair those things together and tell a bigger story. So for instance, Jeremy alluded to the RAND study. We also participated in the RAND study. Connecticut is somewhere around 227, I think, % of Medicare in terms of overall prices. But you can look at that alongside the hospital's financial performance over time. But then you can also look at that and compare the prices underneath that, like variations in MRI costs across the state, and paint, I think, a fuller picture. Well, are you doing better because you're charging 10 times the MRI costs as your hospital down the street? Or are you doing worse because of that? That's really critical information. And frankly, one of the things we've heard a lot is because of because of the affordability challenges with respect to healthcare, deductibles have been climbing. And that's in part because employers are moving costs onto consumers because of the underlying cost of care. But when you start seeing uncompensated care rise a lot, that points right to a potential affordability issue. And is it plan design, or is it price, or is it both?
Yeah.
So these financials are actually critical determining those things. So we could talk all day about it, but those are just some of the points. Some of the points.
Okay, and a reminder to folks, put your questions in the chat box, and let me give Jeremy the last word on this question.
Thanks, and I'm going to two similar slides here. First, let me talk about the hospitals, and then I'll kind of step out. So I think starting at the bottom, I really see, I agree with everything Vicki has said. I think we're very similar experiences to how the data has really helped us understand and where we're trying to go and trying to piece together a bigger story. And step one is collecting the data and getting that foundational data. And and we very much are moving in the direction of trying to piece it together with other data sources we have. But I don't want folks to think that's a barrier to start. I think you got to start somewhere, and you got to get comfortable, and this is a pretty critical place to start. And once you have that data, and then you're going to start asking questions. You're going to look at it and try to go, well, why? And should we be worried about this? And I think that then leads into accountability and transparency, and ultimately is going to lead into supplemental questions. Something that's on my mind, coming back to sure something you said at the outset, that not all hospitals are in the same spot. We just got our Q2 data. We're about to release it in the next week or so. And I went back to my team right away and said, great, you showed me the aggregate numbers. I want to know this broken down by our independent critical access hospitals. I want to know what's going on with our smaller systems. I want to know what's going on with the larger systems. What's the differences, or how's COVID impacting them differently? We're a state that has urban, rural, and then frontier areas, high desert that people often don't think about in Oregon. That's can be hundreds of miles away from other main hospitals, and so they're just in a very different spot. They have 20-25 beds and run an average census of 5 to 10. And I've heard some of them say, I've got to figure out how to start doing some joint surgeries because I've got to figure out new revenue streams. And, I want to be like, let's hit pause. Let's talk about that. We need an emergency room open in rural Oregon. There's going to be ice storms. There's going to be accidents. People are going to have heart attacks. So let's think about, what do we want the system to look like? So I think this data will really help, I think, frankly, have some conversations that you may not even be thinking about until you start to see it. We're very much going in the same direction as Vicki said. We're in the process of creating a statewide cost growth target, and that's about measuring and trying to hold the system accountable to staying within a budget. But I think more importantly, it's about us bringing together the various data we've been collecting through our all payer claims database, through our hospital finance reports, even things like our ED discharge data, and just trying to workforce data, coverage data on who has insurance. I think this is about us moving in a new phase of, instead of putting this all online and just saying, find it if you can. It's really about us, I think, trying to piece it together and doing what I see as our duty as an agency of informing the public and the media and the legislature around what's happening in the healthcare system to help them have conversations around where should we be going. So at the bottom, here our foundational data has been this, hospital finance reporting, as well as our all payer claims database. But we've got other pieces that I talked about, like workforce and ED discharge. Moving into the next phase of that is really around accountability for meeting the cost growth target, and using that data to put out an annual report and annual public hearings to say, here's the trends we're seeing and the things that we think folks should be paying attention to. And that's already starting to spur into what are supplemental analysis that we want to do. We want to start maybe tracking how we're doing on fee-for-service versus value-based payment. I think to Vicki's point around what are the trends from inpatient and outpatient, what does that mean in terms of prices and how we move to value? We've been putting out reports around primary care spend and how that's changing. And I think are thinking about ways that we monitor mergers and acquisitions and what that means for not just prices, but what does that mean for communities that, and what's the healthcare system going to look like? And is it going to serve folks that need it, after some of those transactions? So, we really see this as a way to kind of start to bring together more information. And again, I want to get the data out there, and then I want to have the conversations with stakeholders and say what's going on. Tell us what the challenges are. and really where the opportunities are. So I would really just, I think, again, applaud NASHP for taking a step forward. And while we have a lot, I think, in Oregon that we're trying to bring together, I don't think you start somewhere. And I think this is a really critical place to start.
Thank you. Let me again ask people to add their questions, and let me start with one. The cost growth benchmarking that both Oregon and Connecticut are launching, building on Massachusetts' extraordinary long history, sort of begs the question: if we see from these hospital financials the diversity in the financial health of hospitals, how if they're not an aggregate conglomerate and they're all different, how do you hold them to the same cost growth benchmark, or should you?
Well, that's a good question. I guess I'll take a stab at that. Well, here's the thing. The thing we do know is the overall costs have been growing too rapidly for people to absorb in the state. And in Connecticut, the economic growth has been somewhat held back, and our income growth, just a report today that came out that our personal income growth is 50 out of 50 for the last year. So regardless of what the target is, the importance to me is getting the data out there and having the transparency to be able to look into it. So you may say, like in Connecticut, our target is we're not as obviously mature as Massachusetts is in its program. At this point, we are about getting the data out and getting the transparency out there, and not necessarily talking about punitive measures, as one hospital might be more capable of staying within the first year's benchmark than another. We're more interested in where are you going, and where are these expenditures going, and how healthy are you, and how can we target interventions that cannot jeopardize the health of certain hospitals who may be smaller and not able to absorb it, but seriously also tackle the issues that consumers are facing every day and employers in the state of Connecticut. So that's a very political answer I just gave, but I think it's the right one. I mean, I don't know that there's ever an ideal target that should be adjusted up or down. The whole concept of benchmarking is radical transparency in my mind, and getting the data out there and looking at it. But Jeremy may have a different take on it.
No, I think I totally agree with everything Vicki said. I think everybody's in a different starting place, and what our cost growth target bill is focused on is bending that overall rate of growth from 6.5% to 3.4 is the number we picked. And there's underlying costs underneath that. People are in different starting places, and I think there's going to be ways to try to get at underlying costs that exist now, and I think there's things that can get at the cost growth, and both of those are important and are ways to get at bending the cost curve. And I think more than anything, it really is about transparency, and what we've learned from doing cost growth target. We've had a cost growth target for our public programs for most of the last decade, and what we have learned is it's just, if you don't have that, it's like, how do you even maintain your monthly expenses if you don't set a budget for yourself? You're just going to go spend, and then you're going to look back at your credit card at the end of the month. And that's kind of this healthcare system we have now. We just say, I don't know, I need this now. And then next year I'll look back and say, what did I spend last year? And I think this is about saying, we need a budget. Maybe we'll blow through the budget. Maybe there's a good reason we had to blow through the budget. The car broke down. I wasn't expecting that. Yeah. But I'm trying to budget, and I'm trying to hold to it, and I'm trying, and that's been our experience in public programs. Some years we meet the target, some years we don't. But it's forced us to say, what's going on the ground? What are the cost drivers? And I think the other piece I would say is we really coupled this with a value-based payment strategy, and that was important. It was in our cost growth target legislation when it passed, but I think for a different, we had now a different reason for that. At the time, it was, fee-for-service system drives up, it's focused on prices, focused on price increases, focused on volume, and that's not good for sustainability. But we've now seen the opposite problem with COVID, where we saw revenue plummet when elective procedures stopped because everybody was on a fee-for-service system. And so I think to your point around what about folks that aren't as financially viable? Let's get them on a value-based payment. Let's get them on a predictable, sustainable revenue stream that doesn't have them, trying to find new procedures that maybe they aren't best situated to do, and is also sustainable for payers and for the state budget writers.
Great. So we've got some questions. What kind of capabilities does a state agency need to start the work? Where should they be housed? What kind of skills, staffs? And I guess I would add to that, do you need an APCD?
Well, I don't think you need an APCD. I think every state should have an APCD, but I don't think you need it in order to start collecting, hospital or health system financial data. They aren't the same. They tell you different pieces of the story. As an example, we can use our APCD to see what's happening with outpatient prices as we're seeing this shift from inpatient to outpatient, right? And what's that mean? So it tells you a different side of the story of what's going on. Where it's housed, we're in a state that has an umbrella healthcare agency. Not every state has that. So it works well for us because that's the environment we're in. I don't know that it matters. I think it could sit in a variety of places. I think the important part is it sits in a place where people are going to use it and are going to share it, and they can do the work to get it out there. You can get it out there publicly.
Yeah, and I agree with that. I think you have to, if it doesn't sit in an agency like Oregon's or like ours that has data underneath it by the nature of our statutory, our statute, which puts the APCD inside our office along with the hospital reporting. You need just have a way for those agencies to work together. In terms of staffing, I do think and Nancy is probably the expert to chime in on this, but we have people who understand financials in our office. If we didn't, I think it would be really hard to do this reporting otherwise. So I do think you need, a bare minimum of understanding of financials, unless you want to rely on consulting support or something like that. You do have to have that kind of expertise, but I would let Nancy weigh in on that.
Well, I would just add, we have a team, and it helps because we've got lots of data, and so we can use a team. But we've really got one staff who's deep on this and knows this stuff inside and out. And if that gives you some context, you probably get by with less than that, but it is helpful to have somebody who is really focused on this and understands it. To Nancy's point earlier, it's pretty complex stuff. And even every time I'm like, okay, remind me again, what's our difference of definition between bad debt and charity care and uncompensated? I'm like, come on, Stephen, remind me again. So, it's good to have somebody to go back to.
Nancy, want to weigh in?
Well, sure. I mean, absolutely, you have to have financial literacy at some level. And I think the process of standardizing and putting out the regulations around that requires it as well. You can't explain to the hospitals what you want. You can't defend the glossary. So you need some kind of expertise. I mean, I still get calls all around the country from both state agencies as well. More the media, though. And really, it doesn't work to have zero financial literacy. They don't even know what a balance sheet is. So you've got to have some repository, whether it's a contract with a business school that does that, or you get somebody. I know in Maine, there's been one person who's been there for the whole 15 years. Thank God, they won't let her retire.
Right.
But yeah, someone needs to have that expertise, and then treat them very with great respect and lots of rewards.
Okay. What about, this is an interesting one, whenever we talk about price transparency, people think about consumer shopping and consumer price transparencies. Is there any value to all this data for consumers?
Unless they're financially literate, the people who translate it for them are usually the media. So generally the people who are looking at this data and trying to make sense of it for the general public is the media. And so, I mean, I'm thinking of restarting something I did for years, which is educate journalists in formal settings on how to use health financial data. And there were many people would show up for that. And I'm still getting calls from that, years and years later. Consumers aren't going to say, I care about, I guess if they knew they were walking into a hospital with just declared bankruptcy, it might give them pause. But it doesn't, I think it's a more of a policy issue than it is a consumer issue. It's not like, how much is this going to cost me? And there is no necessary correlation between quality and financial health. So, it's not so much consumer individual decision making. It's more education, and then helping the media understand, and then translating that more into, what does that mean for me and as a community? Is my hospital going to make it? And should I get engaged in community activism and then protesting this merger? It's not a purchase decision kind of input.
But a good,
Yeah,
whatever data we have has to be translated. Jeremy, sorry.
Yeah, I don't think there's very good evidence out there that consumers are going to shop around for most stuff or are that price sensitive unless they really are in a situation. I do think that there's an interesting question of if this was really in providers' hands at the time that they're making referrals. And, I think there's questions of how exactly that happens. And so maybe as we move to value-based payment, having providers understand price is important. To me, I think this is the point of, I see this as a duty of our agency. Consumers want a healthcare system. They want it to be high quality. They want it to be affordable. It's our job as a state agency to make sure that's happening. And this data helps us understand that. We've been putting out annual price variation reports on top 50 inpatient, top 100 outpatient for the last, 5-6 years. And it's really interesting. What it tells you is that there's no rhyme or reason for anything when it relates to prices. That's sort of the takeaway. But I think, I think it does, I had an employer I was talking to recently who had hired a consulting firm to tell him that information. And I said, it's online, right? Like we have it right there. And he's like, what? I had no idea. So some of this is, I think, work in the state act as a sort of utility, get data out there for folks so that, folks have it. But I think for us, the pricing piece is the most important thing has been watching the average increases year over year and seeing that prices really are the challenge. And I think to the point we talked about a couple of times now, which is as services move around from inpatient to outpatient, what's the price impact of that, and then what's the cost impact of that?
Yeah, and I think I would say for Connecticut, similar. These themes are similar across the country, but in terms of the financial data, people will sort of get the concept of the margins and how is the hospital doing versus another hospital is very relevant to people, and or in our case, the top 10 compensation packages from each hospital is one of the things that's the most zeroed in on every year by people. I think where consumers do get active is in the area of surprise billing potentially, and in areas where you have a sophisticated consumer who can actually, look at this and shop for care. There are sophisticated consumers who could do that. But I agree with Jeremy on the employer side of the equation. This is huge for employers, and I think for the state. So for our state, when it's doing its planning for the employee plan, or employers shopping for care or trying to know how hospitals are doing financially and vis-a-vis the APCD, or comparing these data, they can make better decisions about how they decide on plan designs and where customers are going to go, whether, consumers who are employees are going to go.
Great. Let me stop it there. Nancy, the Dean of Hospital Transparency, she started by telling us she's been working on this for 40 years. It must have been heartening to hear Vicki say radical transparency and Jeremy talk about how this can actually be used for policy. So I want to very much thank this great team who is, we're available to you, states who want to engage in this. There is model legislation, model guidebook, a model template on our website. We encourage you to use it. But I very much want to thank these great panelists, Nancy Kane, who's been working with us and working with all of us for so many years on this important issue. And we've got to jump it to the next stage, and I hope we can. Vicki Veltri from Connecticut, Oregon's Jeremy Vanderhay. Thank you all. And please, everybody, stick around for 2 minutes. Just let us know this very short survey if this webinar was of use to you. I hope it was, and I thought it was fabulous. Thank you, you three, very much.